So I'll just quickly want to thank everybody for coming, especially our lovely panel here. I'm Rylan Helstern. I'm the secretary of the Families and Health Special Interest Group with CFHA. And so today we have a lovely webinar that's going to be focused on kind of ethical practice in integrated care settings. I want to quickly introduce our panelists. We have Dr. Jennifer Hodgson, who is currently working with Health Management Associates, Dr. Tai Mendenhall, who's at the University of Minnesota, Dr. Angela Lamson, who's at East Carolina University, and Dr. Lisa Tyndall, who is currently the interim co-director and associate director for the Center of Excellence for Integrated Care. I don't want to take up a whole lot more of our time, so I want to turn the time over to our panel to get started, and we'll leave some brief time at the end for questions.
Wonderful. Well, thank you so much for having us today. We're really excited to join you and to talk with you a little bit about ethics in integrated care. Bear with me as I toggle through some different technology here, which is actually a great part of our day today. So we're here to talk with you a little bit about some specific elements of ethics in integrated care. And a lot of the work that Lisa and Jennifer and Tai and I have focused on over the last couple of years has actually appeared in a new textbook called Systemic Ethics Textbook, which was edited by Christina Brown, Dr. Christina Brown. You'll find additional information about what we're talking about today in chapter 23, which is entitled Medical Family Therapy, Ethics in Healthcare Settings. We also want to encourage you to remember that there are family therapists in healthcare competencies and that AAMFT is currently going through some updates on code of ethics for family therapy, which directly influences medical family therapy as well. So I just wanted to share that with you. And so today our process is going to be to talk with you through a vignette and then to begin thinking about ethics in 4 particular areas in relation to integrated care, including our scope of practice, our technology, the larger systems, and record keeping. So let's go forward and let's meet Charlie. Tai, would you like to introduce Charlie's information, or would you like for me to do that?
Um, I'm one of my monitors is dying, so if you could do that, I think that might be better. I apologize.
No worries. No
Computer's
worries at all. So let's meet Charlie. Charlie is a patient who is seeking care for in vitro fertilization options after experiencing difficulties in getting pregnant. Charlie is 38, and she arrives with another person to her visit named Tommy. Charlie always knew that her pathway to pregnancy could include some unexpected challenges. They wanted to be a mom for a very long time and worked their way through about a half a dozen providers that they struggled to connect with. They had heard good things about Dr. Hai, and so they had arrived today just a few minutes ago for their first visit in the OBGYN clinic that you work in. You have gone in to see Charlie, who has been joined today by Tommy. You are excited to see that there is a patient that brought a family member because, as a relational therapist, we always want to engage in the patient system. You introduce yourself as the medical family therapist and that you're part of the patient's healthcare team. You share that you talk with patients about experiences like stress, sleep, family support, as well as experiences with symptoms of anxiety and depression. The patient gives you consent to talk and provides consent to allow Tommy to stay in the room as part of the visit. Charlie is so grateful to finally be in a practice that cares for their whole health and begins to ask questions about hormone levels, tracking menstrual cycles, and is curious in learning from you, your take on Dr. Hai's belief systems about patients. Tai, I turn it over to you.
Well, I appreciate that because I'm not seeing much here on my screen, so I'm kind of doing this verbally. I don't know, but as we as we look at ethics, as we look at scope of practice, I think that uh, there's the baseline training that we oftentimes get in. All of us are familiar with AAMFT's Code of Ethics as that baseline. But then as we look at the different places, and in this case, medical family therapy, family therapists and healthcare are going, it pretty quickly gets a lot more messy. I mean, there's a lot of cooks in the kitchen. There's a lot of history, and there's a lot of people that are involved in comparison to, I think, more of that private practice. It's just you in a room with folks. And as we look at and we brainstorm really kind of about this patient scenario, there's different things that we might want to think about and consider. I mean, the relationship dynamics, family support or not, what's the provider's belief system, cultural contexts, etc. And I think already as I hear this vignette, those things are on my mind. And with scope of practice, in some regards, I would imagine, yeah, that's within my scope. But what about all of the medical stuff that's going on in here? And my impression, and I can get up on a soapbox here if I'm not really careful, is that most of the time, going back to our training, it's pretty easy to be kind of discipline centric and think that your ethics code is the only ethics code. And so there's potentially other ethics codes that are happening. What are the physician's ethics codes? Are there sibling disciplines that are involved? And do these ethics codes agree with each other, or do they not agree with each other? These are things that we need to be curious about and navigate in a way that that's cautious. I mean, we always say that it's better to prepare than it is to repair. And I would, just as examples, that if you're situated in any types of these contexts, it's very likely that you might feel like you know some of the answers to some of the medical questions. You might feel like you can speak for a physician when the physician isn't there because you've heard this a number of times. And pretty quickly, you can start to get really out on some crossroads here on what is in my frame to do well with and what is in my frame to collaborate effectively with. Okay. And I think that we need to really kind of engage with that curiosity and connecting the dots along the way versus that baseline training that we all have. I'll stop there because I think in a lot of ways we can get more specific from it. But I'm wondering what other attendees or other presenters are thinking in terms of hitting their radar to say, yes, I can do that. Okay. Yes, maybe, and no. And how do we navigate that collaboratively with my colleagues? Oh my gosh, now I can see it. Okay, I think my technology is working now.
Okay. That
Yeah,
might have been
so,
on me, Ty. Sorry about that.
okay, yeah, thank you. I was just kind of looking at a blank there. That helps now that I can see the slide. Um, oh, and I would just say one more thing, but then open it up to other thoughts from colleagues or participants here, is on the final 2 points here. A lot of times these questions are maybe easier to navigate when we're looking at our physician versus mental health provider. Sometimes that's pretty clear. No, I'm not going to give medical advice, even though I might know it. That's not my role. But then when we get into the sibling disciplines, you know, we have psychology, social work, chaplaincy, and of course, different versions of that: child psych, adolescent psych, industrial psych, geriatric psych, early childhood, medical family therapy, baseline family therapy, medical social work, social work. There's an awful lot of overlap potentially, but there are areas of expertise that we need to walk the walk on that are going to echo some of those mental health generic, biomedical health generic boundaries and overlaps that we have with each other.
Ty, I was thinking as they're getting warmed up a little bit, because
Yep.
we want this to be really interactive, is that in this case with this patient, with Charlie, and they begin to really be so grateful that they've got somebody who's a great listener, somebody who's invested in their relationships and in the bigger aspect of their health. And start asking questions related to their hormone levels or other aspects of their physiological well-being, how can we ethically think about what is our role in that, or what are some of the ethical pieces that we can do to enhance both keeping the relationship but keeping our ethics as well?
Yeah, and I think that that gets at more of the kind of the real life application of maybe what I said kind of as a generic introduction there. Because if this is something that you're up to, again, you might have heard similar questions. You might have been working here for a year or 10 years and authentically, genuinely in your heart know the answer. But you're a mental health professional, and this is more the scope of a physician that they might say the same thing, but they also might see different nuances or understand different parts of this patient's physical presentation that they would answer differently. And so, as a mental health provider in this type of setting, in the example that you just gave, being a collaborative finder outer of information, to say in your own voice or your own words, yeah, this is a good question, and this is a common question, and we've certainly talked about this. Let's circle back with, X, Y, and Z, and get a sense of what they're thinking. Or as we put all this together, I know who to ask, and let's go through the appropriate channels or paths to find that person, and you played a really important role there, but you didn't get out ahead of yourself or your scope of practice and do somebody else's expertise or work inappropriately. And then at the same time, you're connecting to that because maybe the information is hard, and maybe the emotional experiences of that, maybe this is exacerbating anxiety. Maybe somebody's really worried about this now. Okay, you compare some of that. Okay. But as you go forward and everything that means, you are walking alongside people sometimes more than you're walking out front.
I like that second part of what you said, especially Ty, because not only are you staying in your lane, so to speak, but you're also like thinking about agency communion between the patient and the like the patients and the providers, and then yourself. Like you're really thinking about that whole relationship and building trust and referring them back to the provider, which shows your trust in them, and it's just all combined.
The one thing I'll caution about, and I've seen this happen, is that sometimes it's not the behavioral health providers that are creeping outside their scope. It's the medical professionals that are asking them to creep outside their scope. So they'll say, Rylan, what medication would you recommend for this patient's depression? Or Rylan, you've been with us for a while. Do you think you could go in there and talk to them about what this procedure is going to be like? And certainly Rylan can do that, but I would feel better if Rylan would first confirm, okay, here's what I would say. Is that consistent with what you're thinking as well? Because what happens over time, and I tell everybody I train in ethics this, it's not the new professionals that I worry about necessarily, it's the people who are really seasoned, because they've been in that environment for so long, sometimes the boundaries get a little blurry. So I always encourage like a check back with the provider, no matter how many years of experience you have, just to make sure what you were thinking, intending on saying is consistent with what they're seeing within your scope. So, and trust definitely will come over time. We've seen that happen, but sometimes trust can also be a problem. So.
It's such a great point, Jennifer, about the length of time and the ways in which we think through the processes. I can't count how many times MedFT trainees have felt accountable, like they need to know everything that they possibly can about all of the language and all of the different experiences that could possibly come into contact with. And yet I think that newness has a lot of great assets to it, to be curious and wondering with the patient about what they need, rather than relying on too much of that experience to try and answer it, even when they maybe shouldn't. So I don't know if I'm sorry, there was somebody wanted to
if I could just build on that, as well, is that, you know, everybody has that, again, that baseline training, but one of the things that we encourage, and I do think it's good practice, is to say, okay, I'm going to go work in this pediatric, you know, oncology, you know, site now, or I'm going to go work in this diabetes clinic. And to get ready for that, we encourage trainees to learn about that context, learn about the diseases, learn about the medicine, so you can navigate conversations, so you know what people are talking about, so you can read a note from a physician and understand what's happening. But that doesn't give you license to be offering advice around what you just learned about. And you might be really excited to offer the advice because you know the answer. You spent a lot of time learning about it. But back to what we're saying, you got to do that cautiously and collaboratively with your colleagues.
Thank you, Tai. We're going to make sure that we have time to interact throughout these experiences, but then also we'll have time for question and answers at the end as well. And to that point, Tai, you might even have a little red book that you've written or edited that has some of these key skills, language, et cetera, on how to go between different kinds of locations. So Charlie is back for a second session, and this one they invited us to consider having a telehealth visit. So Charlie had requested that their second visit was done through the clinic's telehealth option. When you go into the clinic's telehealth system as Charlie's therapist, you realize they are talking to you from the grocery store. They opened up by saying that they were almost done at the store and didn't want to cancel their session. As they're checking out of the store, they mentioned to you that their partner Tommy was so stressed after the last visit that they gave their login and password to the patient portal, to Charlie's patient portal, to their mom, so they could help Tommy understand what was documented in the labs. Lisa, I turn it over to you.
Yeah, I'm curious for the participants that are with us, like what concerns pop up for you when you hear that your patient is taking a call from a grocery store. And I know that's happened, I'm sure, to some folks on this call. Or if it hasn't happened, how would you respond or what would you do? You can type it into the chat if you don't want to talk. I get it. We're all introverted here. I'm just kidding. Not all of us.
I mean, I think confidentiality is the biggest red flag that comes
Right.
up about if they're in a, you always want to check in if they're in a safe, secure place where they feel like they can feel open and comfortable to discuss things. And in a public setting where you're not sure who's around and who can overhear, you don't really have that security at all.
Yeah,
Or
no.
their focus.
Or their focus. That's what I was thinking too. I know because sometimes I'll want to talk to my dad will call me and I'll think I can talk to him while I'm in the grocery store. And then I've like, it's a train wreck, right? Because we can only, our brains and hearts can only be in so many places at one time. And so being able to make sure that they get the value that they, of that appointment, and this was an important appointment, and making sure they benefit from it as best way possible.
I tell them too sometimes, Lisa, that it's not even so much, you know, just that I want to protect their confidence, but the perception of others seeing might think that therapy, if they've never experienced therapy before, they might think that there are no boundaries in therapy and that this is a normal thing. And so when we make an exception, it's not even just with the person we're with, but it's everybody else who might be observing that exception and then walks away with a misunderstanding. So I think that's the other piece of it. I once had somebody approach me in a grocery store. This was when I lived in another state and wanted to update me on everything. And it was really, really uncomfortable. So even thinking about just the in-person part of this, but then telehealth, you can't see. At least I could kind of see who was around and keep my voice low. With telehealth, you can't see that. And unless they have earbuds in or who knows what, you don't know how far you're traveling and who's hearing it.
Yeah, that's a great point. Anybody else?
Well, I would just jump in and say, like in my experience, I've had people do that from their car. And you know, the reality is you only see what's in your screen, but you don't know who the passengers are, and they're not always telling you who the passengers are. Or even if they are at home and all of a sudden you see somebody that you don't know walk by in the background. I mean, there's a lot of things to be thinking about when we're connecting with people remotely.
I think that's a beautiful example of the benefits, but then also the risks, and how do you balance that? How do you balance those two things? I think it's ironic that I'm talking about this section because I have such a love-hate relationship with technology. Um, I kind of want to smash all the computer screens in the world, and then I understand that it allows me to work from home and see my father's face far more often than I would normally see him, and my child now who's at UNCW. But anyway, thank you for the good discussion around this potential dangerous or unethical interaction. We can move forward to the next slide, I think. So I think the funny thing about technology is that it is has been around for, especially for MFTs, for a super long time. When we think about what we used to consider technology as far as telephones, and putting little bugs in ears, and being able to kind of use, I mean, if you even think about the one-way mirror as a way of technology, as something that's in between and intervening, so that we can use or get a different perspective on things. But as we just kind of highlighted, it can also blur boundaries. So it feels it's with us everywhere, right? Like my husband is horrified when I don't respond right away, because don't you have your phone on you all the way? Like you can't walk out into the yard without it, or your wrist buzzes or whatever. And so it's with us all the time. And then we have this bizarre sense of open access to people's lives and to people responding. And so that can be a challenging, especially when a relationship develops, kind of like we were talking about in the case of Charlie, after such a long time of trying to navigate the healthcare system and in such a precious time of life. So patient education upfront and ongoing, being really clear about what we use different mechanisms for. So thinking about secure messaging on a portal versus text messaging, and maybe gentle reminders about that. Privacy on their end and on our end, and taking, I think, a minute. If you have a client, for example, in this instance, if it was possible, now we didn't mention how long that appointment time was for, but saying, it's okay, I can wait. Like I can wait for you to check out. I'll be right here, and you stay on the line, and they make it to their car, and then you have a conversation about who they're with, and you assess for those sorts of things for their benefit. And then, of course, on our end, making sure you're in a secure place. But that's a variable we can control easier. And I think that privacy on their end, I think just as we mentioned, even if you're not in a public setting, being able to see who's in the room. I, as a patient, have done telehealth plenty of times. I don't think I've been asked once, to show my screen or to see the room or whatever. And I'm thinking right now, I have a telehealth appointment as a therapist tonight. I'm thinking, oh, am I going to ask her to move the camera? I guess I should, that's right. That's best practice. But the truth is sometimes it can feel a little bit awkward, or we take for granted, or as Angela said, or Jennifer said, whoever it was, that we get more comfortable. And as we get comfortable, we don't take those necessary precautions. So, yeah. And then just thinking about things like patient portals and other ways of using technology that you, as a person who uses it on a day in and day out basis, find it very easy. And we may say it's very user friendly. But for a lot of folks who don't use those things on a daily basis, especially if you're working with an older population, I know I've had patients just specifically ask, or actually I've offered and said, I have a portal, but I can also bring hard copy paperwork if that would be easier for you. And they're very grateful. And just knowing that we need to make either adjustments so that we are accessible and our services are accessible and communication is easy. But also that it's, I lost my train of thought, to be honest. That's accessible. It's totally lost it. But also, anyway, so just making sure that everyone understands or has the best way, kind of like language, also making sure those documents are in everyone, as many languages as possible in terms of accessing that technology, making sure that it's easy to understand as well. So working within a medical or a healthcare setting really expands those possibilities, because now you're not just working with your records, your clients, these are our clients, and thinking about being able to have that increased ability to collaborate with folks, but also thinking, okay, what I'm writing in here may be accessible to additional people. Who are there firewalls in place? Are there things in place that automatically protect the information, and who has access to what? Understanding that. But on the plus side of it, there's that sense of team, right? You can perhaps see some records or notes from the provider, and then you can write yours so that you can connect those biopsychosocial spiritual dots in the notes, so that that helps the medical provider, right? It's that whole kind of cycle together. And then there's just sometimes layers of fine print missed for the patient consent, and like that risk of inappropriate records access, and not getting tempted to look in places that you're not necessarily supposed to look also, because you may have access to things that you don't necessarily need as well. And I think that the risk there increases the more comfortable you get in your setting, and the longer you've been practicing. So yeah, pros and cons of technology all around.
Tai, it looks like you've got a question or thought.
Yeah, I really resonated with well, really with all that you just said. But one thing that I would add too, with like the firewalls, you know, are you walking the walk in terms of what you need to do with the multiple hats that you wear? And that might not make sense. So let me like be more specific. So for example, a lot of us that work in university settings, the university provides us a computer and a laptop, okay?
Mm-hmm.
But then we're also working at a clinic or a hospital that overlaps or is separate from that university, and they give us a laptop.
Mm-hmm.
Now, you might be able to check email from either laptop. But are the laptops equally secure in terms of the ways that they're set up? And we need to be really careful about that, because a lot of times well, I would say not a lot of time, I'd say most of the time, your university issued computer, I mean, you're on a, you know, maybe a Duo security, or you have, you know, an Ethernet connection, and you have various logins that you can do when you're on campus, but does that apply when you're at home? And can you access patient data from that computer? Can you do your therapy session with that computer? I would say, even if you could, you probably shouldn't. You need to be switching out your laptops and using your clinic or hospital issued laptop, because they, again, almost always will have different layers of security happening, that are important to abide by with that private health information. And you know, it might be inconvenient for you to always be thinking about which machine am I using, but it's good to be thinking about which machine are you using.
Mm-hmm. That's a great point. I hadn't thought about that.
Wonderful. Thank you, Lisa. Thank you, Tai. I think we're going to be turning now to Jennifer for Charlie and Tommy's third visit. Charlie and Tommy just found out that they are pregnant. Recognizing Charlie's age, pre-existing conditions, and the medications they have been on for many years, there were several providers you felt may be helpful to connect with to best support Charlie during the pregnancy. Charlie provided you a list of people they rely on to sustain their health, which includes their psychiatrist, reproductive endocrinologist, an oncologist, a pastor, and now an obstetrician from the high-risk fertility clinic. Jennifer, we turn it over to you.
Great. So the lens we want you to be thinking about with this is larger systems. So when we think about larger systems, what are some of the larger systems that influence our clients and their healthcare? So in this instance, what are some of the larger systems that you're hearing about regarding Charlie and Tommy's network? Let me just give a couple examples. I know Angela kind of read through them. Do you hear any larger systems? If not, we got to go back to systems theory, folks. Okay, so there was a key sentence in here that Charlie provided you, the behavioral health provider, with a list of people that they rely on to sustain their health. Their psychiatrist, their reproductive endocrinologist, their oncologist, their pastor, and now the obstetrician from the high-risk fertility clinic. So those would all be examples of...
Maybe you need a drum roll.
I know, larger systems. What is the challenge ethically then that you have as a behavioral health provider? So once somebody tries to tell you they're working with all of these people outside of the work they're doing with you in the clinic, what's the first ethical bell that needs to ring for you? I'm going to pick on Rylan. Look at him. Come on, Rylan. What's an ethical bell that rings for you?
With larger systems, when they're working with other
Right.
providers,
Yep.
I mean, the thing that comes up for me is release of information and wanting to collaborate and make sure we're not doing anything that's contradictory.
Perfect. So even though they see all these people are on their team, know all their information, it is part of our code of ethics, right, as family therapists, that we all have a signed understanding. Now, there's a difference of within facility and outside of facility. So tell me a little bit about what you know about working with larger systems inside the facility, in the walls of where you're working. Does anybody want to say what the difference might be between talking to one of them and talking to somebody outside the facility?
I think sometimes we can see within systems that there is a mutual understanding that information can be shared across professionals.
Keep going, Brittany. Where would the patient be informed of that?
I think sometimes patients don't always read that, but it's usually in the general information that they get at the onset of establishing care.
Ding,
Right?
ding, ding.
Yeah.
That's it. That's it. So our job as behavioral health providers, when we get to a new site that we're working at, is saying, can we see your established patient information? Because I want to make sure that in that information, it covers that I can talk with Lisa Tyndall, Tai Mendenhall, Angela Lamson, Rylan, Brittany, is they might have different things throughout the clinic, services they might provide. So as long as that's in there, we're good. And then what we need to then explain to our patients is, because some of these people might be operating outside of our facility, maybe they're in the same neighborhood, in the same campus, they're just outside of our facility, then we might need different releases of information to talk, and also clarifying for them what information they want shared. Because it may not be that all the things we're talking about, they want other people to be aware of, like their pastor, for example, right? There may be certain scopes of information that they're comfortable with and other scopes that they're not. So even with those releases, it's important to have that conversation that we're limiting the information to what it is they want the other person to either know or they want us to receive. Because remember, releases can go one way, not the other. So you can sign one that you only are to share information and not to get, or only to get and not to share. Most releases we assume are bidirectional, but that's something else you want to make sure you're reading as well. Okay, lots of hands were going up a second ago. Who wants to jump in? Brittany? Did your hand go up or no?
Nope. Exactly what I was going to bring up is I've worked with patients in these settings before, and they say, well, I've told you this, but I don't necessarily want, my specialist to know, or my PCP to know, or I'm still trying to figure out how to bring that up, or I'm scared it's going to impact my care in some way. So, even though those releases are there, still having those conversations with patients about how information is shared is important and what they want disclosed.
Absolutely. Even within facility, because they may not want their provider. I had somebody I was working with a long time ago who did not want their provider to know that they were LGBTQ. And they had a really good relationship with their provider. They were getting really good health care. But this was just something they were worried would change the relationship, because they didn't know where their provider was with their own belief systems. So we worked on that for a while to find a way for them. When would it be appropriate? Is it even appropriate to what they were getting care for in that moment. When would it be appropriate? So we really talked about that. And then I had to be very careful, and this is the other part of larger systems, is in my documentation, that I was being careful who had access to my documentation, and that I was documenting authentically to the billing and the work I was doing, but not adding in extra information that would in any way breach that trust and confidentiality. Okay, Tai.
Yeah, I would also just maybe want to highlight something that I think happens that we all know, but we don't talk about very much. And that is that a lot of times patients don't really read these forms. You know, I mean, they come into the clinic and they want to see somebody and they get a bunch of stuff to sign. You know, it's kind of like when you get your software update and they want you to read 5 monitors of fine print and then click I agree at the bottom. I mean, how many of us really read it before we click I agree? You know, and so I think a lot of patients when they come in and they're establishing care, for example, and it's an integrated environment, and part of that paperwork says we are a collaborative team. There's a lot of disciplinary cooks in this kitchen. We share the same electronic medical record. And by signing this, you are giving us permission to collaborate and talk about you, with or without you in the room. And I've found over the years that a lot of people have no idea that that is happening. They're like, oh, you talk to my physician? Oh, well, I don't need to, and so I just think along the way, kind of like with good research, that you always have like ongoing consent is what they call it. You return to the consent, you talk about it, you clarify it, etc. It's important to always be having conversations verbally about this instead of saying, oh, they signed it, so it's okay to proceed.
And I know we're running close on time here, but I also, one of our responsibilities too as behavioral health providers is to educate the different parts of the system on the ethics of that. So when I join a new practice, from the front of the house to the back, right? Front, I'm going to be talking with them about when the phone call comes in and what is shared and who gets to, see what about that patient's file. And every time we walk into a new practice or a new environment, we have to figure out who has access to information, who needs to know what. Sometimes people are very uncomfortable understanding what to do when it comes to behavioral health, phone calls, and patient needs. And so it's really, really important that we slow everything down and we figure out where those ethical boundaries are. And when we work with the larger systems, how much information in detail do we need to share, and that our patient can ask those questions so they know where all the information is going as well. So the last slide I would say that we had right before this one just talked about the 4 main scopes. So it is important that along with our patients, we identify who all the collaborators are that we would be talking with across all the different settings. We understand competencies of those collaborators, knowing that sometimes the cardiologist may just pick up the phone and call the primary care person, and that's no big deal. But to talk to us, it's a different pathway that we need to get releases of information to be able to do. So we need to be able to understand that and then how we engage around that. Also make sure we're gaining ethical awareness of all the different codes of ethics that are in the setting, and that is our responsibility, and where they might align and not. And then solutions. So how can we and I used to drive my students crazy in ethics courses, but worst case scenario, right? What's the worst case scenario that could happen? And then let's put some solutions in place so that that doesn't. And I like to find out from everybody's jobs in the different place, what their worst case scenario is, because it might be things I never even thought of. So with that, thank you very much. And we're going to move on to the next section.
Thanks, Jennifer. So our last area of ethics before we go to question and answers has to do with our documentation and record keeping. So we really need your help now on what do we need to be thinking about with regard to these 3 very different kinds of sessions. So as a reminder, when we're thinking about initial paperwork, documentation, or record keeping, let's reflect back to session 1 with Tai, that we had Charlie come in with Tommy for this visit, and that you had the opportunity to be asked to be able to share information about your role and also to hear some of Charlie's questions. What are some of the initial paperwork or record keeping things that you would want to keep in mind for ethics in relation to this first visit?
I don't want to keep speaking, but one thought with the first visit, making sure that you document that you clarified your role as the behavioral health provider to the patient and their family member, and that you confirmed that they were okay with their family member being present and that they agreed to that as well. So not only that you explained your role, but that they consented to it.
Great. Thanks, Rylan. You're never going to share too much. I love it. Who else has any thoughts about session one? Any paperwork or documentation that comes to mind for you? Angela, it looked like you were leaning in. I don't know if that was to answer something or not. No. Okay. And so we'll talk a little bit more about some of the things that will be relevant to that first session here in a minute. The second session was our telehealth visit. What aspects in relation to your documentation, your record keeping, do we need to keep in mind in relation to Charlie? Of course, Charlie in this case was at the grocery store, and then also shared as a part of that that their partner had given out their login and password for their partner's patient portal to be able to share with their mom.
Yeah, I think the one thing that comes to mind is just making note of that, right? That there is an additional family member that has access to the patient information. Are there proper kind of records on file giving that family member permission? I think what immediately comes to mind for me is a potential ethical issues, a potential snowball effect, right? Mom now has access, so then will she call up and be wanting to request information about, her child or to speak to the physician? You could just snowball without having the proper paperwork in place.
Great points, Brittany. Those are great points. And we know that the partner gave access to their partner's labs, but we don't know that the actual patient wanted that to happen, right? So there's some complexities there that we need to consider. Great. Any other thoughts on that one? Okay. The third visit was with Jennifer, and being able to think about, in this case, we had numerous larger systems that now might be contacted or interacting with content from the patient's health and healthcare process. What kinds of documentation or record keeping thoughts do we need to have in mind for this visit?
You guys mentioned this piece a little while ago, but one of the things I always think about in terms of documenting when you have multiple different players in the system all taking care of a patient is thinking who needs what sorts of information and what level of information. So if you have a patient who's coming in as for example, a history of traumatic experiences, how detailed do you document? Does their cardiologist also need to know as much detail as maybe their PCP would? And thinking in collaboration with the patient about what that looks like in their record.
Thanks, Angela. You're spot on. And so I think it is really important to know that just because we have release of information without restrictions doesn't give us just the freedom to share everything from that visit. And so I think that was really well said. Thank you, Angela. So when it comes to ethics and record keeping, and I think about this both as a provider, but also as a supervisor, that even in some of our integrated care sites, we have separate paperwork from whatever the healthcare system delivers. And so being able to think about what does our informed consent look like? We've talked about accessibility. We've talked about language and linguistics. Being able to have hopefully someone in your corner that looks at this from a legal perspective is good, to make sure that they're looking out for your best interests. But then also remember that most people who are lawyers are not also clinicians. So being able to have someone that's in your compliance corner that can really think about this more from a clinical lens and how things read for your coverage is important. We've talked a little bit about authorization to release patient information. As Jennifer said so beautifully, we want to think about both receiving that information as well as releasing that information, and to know if there's any restrictions on those factors. In addition to that, oftentimes patients have to sign a HIPAA release, which is separate from their release of information. So whether it's that or whether you're in a school-based system, you may have additional FERPA documentation to make sure that you're thinking about to better protect both you and the patients that you serve. We talked a little bit in this last vignette about patient access to records, and I think that this is a really interesting one. Again, we've had situations where I would say that the clinical work looks very integrated, but the paperwork is not. So being able to know how much information you should access, do access, and then being able to also think about if you are a supervisor, can you access what your student or your learners can access? And being able to think about the layers of complexity there is really important. As we're building new sites, I think that this is an area that's often overlooked, is how much we can and should access patient documentation. Keeping in mind, too, that some of us are in very small areas, and we may be serving a patient who is also our neighbor. So thinking about the facets of dual roles. The maintenance of records is also very important. And so we have, that looks very different in a lot of different systems where there might be some kind of paper documentation that's kept under double lock and key while also having electronic health records. Being able to know what those rules and regulations are, not just for the site, but based on your code of ethics or legalities for your field. And then I put in here too, the oversight by external supervisors. There was an interesting comment made through CFHA recently about trying to start up a new site and wanting to be able to supervise, but knowing they couldn't be on site all the time. Being able to know what access you have to different providers or to supervisors is always important to think about in relation to record keeping. So these are just some of the do's and don'ts that our panel had come up with over time, being able to make sure that we are making timely entries. We are in medical family therapy dealing with some very complex situations at times. And so we need to make sure we're timely with our record keeping. We want to make sure that we're interacting with providers appropriately. And sometimes that's more verbally than through writing for a variety of reasons. We do want to make sure that we're able to upload or keep track of any kind of assessments or documentation that's pertinent to the patient's health in the EHR or in our paper documentation. And then we also want to make sure that we're doing appropriate informed consent for any family members or anyone else that's joining the room. Jennifer and I talk about a patient who was supported just for mobility purposes. And that individual learned more than they should have from the visit because it was assumed they were a family member and not just there to help them with mobility. Being able to remember to do not document information that is outside of our scope. We've done such a great job of hearing from Tai and thinking about some of those scope issues that could create ethical concerns. And then also to be very careful about any kind of abbreviations, medical terms, or mental health terms that we might use that can get very confused. I know that we've had some coding issues over time because it was misinterpreted between ICD and DSM content. So just making sure that we're very careful on that. So before we turn to question and answers, we want to make sure that we're thinking about things together when it comes to ethics. We have so many elements of ethics, but on top of that, we have policies and procedures that revolve around the clinics that we serve. And then, of course, we have state regulations and federal policies that are changing at all the times that we didn't even get into in relation to this particular patient's care. So knowing that we need to seek feedback, even post-licensure, being able to make sure that we know what our code of ethics are, and hopefully being really mindful that those that we work with may also have different codes of ethics and respond differently to situations. Being able to understand the terms of our informed consent and making sure that we know how to convey these experiences with the patients that we're serving. We all talk about CJ Peak's four-world view, so it's important that we're corresponding with the C-suite. Do our financial officers, our operating officers, being able to think about our executive officers, do they understand some of the elements of what we're talking about with regard to policies and procedures? being able to also recognize that there are opportunities to train, and that is CJ's fourth world of that training element. Let's work together with our COO, CFO, CEO on ways to enhance our systems together with the providers and hopefully patient voices as well. And then last but not least, let's make sure we're given accolades when we see it done well. Being able to think about how we're addressing ethical challenges and knowing that we could work through them together is a huge win for everyone. So I am going to move us now into questions and hopefully hear from you. What were you hoping to be able to gain from today that we haven't been able to provide yet?
And I think, as mentioned before, if anybody isn't wanting to speak, you're more than welcome to use the chat and we can do it that way as well.
You know, if I could just jump in, I speaking of dual roles, I mean, here we are presenting, but I also have like I'm observing too, we're participating. I mean, this could be an entire another webinar in and of itself, but a lot of these sites that we work in do research. And then we have different consent forms and we have different roles. Am I providing care or am I a researcher on this that I'm doing X, Y, and Z about? And it can get even more complex. And I don't think that that's a reason not to do research. But I think that we need to lean into that complexity, ask questions, be transparent, talk with colleagues. Which computer should I be using? Which form? Which hat am I wearing? Because when we take all of these disciplines with all of these overlapping but distinct roles and rules, and we put research on top of it, I think that I think that we're doing good work, but we're also navigating a complexity that's even a little bit more detailed.
I have a thought maybe I can pose to the group to get the panelists' take. So I supervise or have in the past in this last semester Spanish-speaking clinicians. And I've also worked with clinicians that have to use some sort of translating services, or a patient brings a family member in that's going to have to translate for them during the interaction. And what are your thoughts on just kind of navigating ethics, particularly if a family member or sometimes even a child is like translating for a parent, right? How to navigate ethics around that, or a disclosure of certain information, maybe that individual doesn't want their family member or child to know. Just thoughts, general thoughts from the group around that, or the panel, I should say.
Brittany, Lisa, Zach, Connor, I will say we don't allow it actually at our clinic because we kept running into this issue. At least half of the patients that we see are interpreted visits, and I'm not going to recall. Sorry, I'm balancing a number of different things, and I got to step off in a second here, and I joined late. And I don't recall off the top of my head what our form says, but if a family member is going to interpret for a patient, there's a form now that our system created that essentially says that you can't then, moving forward, you will always use a family member. You cannot have an outside interpreter anymore, because we believe that you should be using an outside interpreter always, so that we don't have all these funny little issues with family members or children knowing things that they shouldn't, or interpreting words that they might not even know the meaning of in a medical context in particular. And so the two pieces are: one, we don't allow it, and two, if the patient insists, then they have to sign a form saying that they are essentially, waiving their right, for lack of a better way to put that, to being able to use an interpreter in the future that is a non-family member interpreter. That is what the very higher ups at our healthcare system decided was going to be the answer for that.
Thank you, Lisa, for sharing that. And yeah. I know that Jennifer and I worked really closely with the system for a long time. Ryland's been in that system and Lisa's been in that system, that has a service that you are able to use through a tablet that helps to translate in about 250 languages. And so we've been able to rely on that because it's encrypted and it's got some of the elements that help to ease that. But Ryland is a bilingual provider, and being able to have somebody in there that is able to have that confidence and competence, I think is really important. But then Brittany, to that next level is how does the supervision work, and then how to make sure that the ethics are good from there. So that protocol tends to look very different. I know Ryland many times has had that situation where the child may be predominantly speaking English throughout their day, but the home family is really speaking Spanish as their primary language, and how to help discourage, as Lisa said, having a child translate for a parent, or keeping a parent out of a loop. We want to try and make sure we're transparent with all of that. Good. I think we've got time for maybe one more question or reflection before we close for the day. We've included our email addresses in case you'd like to continue to reach out. As we always say, this is the start of a relationship, so stay in touch. But any last questions or thoughts?
I would just say, like, in the future, I think AI is going to have to be a larger part of this. As people are beginning to use AI for treatment plans, AI for notes, there's all kinds of ethical issues with that, because as you know, AI generates algorithms for these things. So they're taking confidential information and using it to create these. So where is that access? How are we protecting patients? When is it appropriate to use and to not use AI? Do we need to be disclosing that we use AI to our patients in the generation of notes? There's also some technology that they can overlay on top of EHRs, where they can, almost like a qualitative researcher, analyze text to be able to pull themes from the progress notes, to be able to create alerts to supervisors if there is language that's beginning to escalate. Maybe the new inexperienced clinician isn't noticing it, but the seasoned provider might. So we really are going to have to stay on top of the technology as our behavioral health providers, and to know what's coming into our clinics and how it could impact confidentiality.
Thank you, Jennifer. Thank you so much for having us today, and for the rich conversation around ethics.
Yes, thank you all for joining, and thank you to our panel members for contributing and for all of your preparation as well. We really appreciate it. Again, this is a really broad topic, so it's really hard to fit everything into an hour. We couldn't cover everything. I know that that was really difficult, so we really appreciate it. And like Dr. Lamson said, if you have any additional questions, those emails were listed, but you are also welcome to email myself, or any of the leadership team of the special interest group for more information. And this webinar will be posted on our page as well in the coming months. Thank you all.
Thanks, Ryland. Bye-bye.